Let's have our invocation. Father, thank you for this day. Thank you for the privilege of being here, the gift that you give us of another day, and pray you'll utilize this time to be productive in your sight. May everything we say and do be pleasing to you. In Jesus' name, amen. Roll call, Shelley?
Yes, sir. I'm going to have to do two roll calls, one for those that weren't involved in an election and one for those that were. So, Mike Dobbins.
Here.
Danny Callison.
Here.
Johnny Kidwell.
Here.
Joshua Sam. Mike Shambaugh.
Here.
Melvina Shotpouch. E.O. Smith.
Here.
Condessa Teehee. Victoria Vasquez. And then the next one is for those that were just involved in an election. I need to know if you're here and if you want to be a part of this committee. So Sasha Black Fox Qualls. Here. Julia Coates. Here, yes. Joe Deere.
Yes.
Kevin Easley.
Here, yes.
Lisa Hall.
Here, yes.
Darrell Legg.
Here, yes.
Dora Petzkowski.
Here, yes.
Cody Poindexter.
Yes.
Okay, we have a quorum and we have 17 members on this committee.
Thank you, Shelley. I assume you've had time to look at the minutes. I would entertain a motion to approve.
Second.
All those in favor? Aye. Opposed? Thank you. Moving on to reports. Before we do, I just want to express my appreciation to my brothers and sisters on the council here for the words of encouragement, prayers. They've really been heartfelt. I think I used up all the prayers, so always welcome those, but I appreciate it very much. Okay, George.
Good afternoon.
Hello, George.
I think you got my report in your packet. We had, I changed it up a little bit. You might know that the month I take all the COVID breakdown off of that, the percentages start going back up. Last week I did get a little bit of some numbers to relay to you guys. We did 236 tests last week. We had 44 positives for an 18.6% positivity rate last week there at the hospital in Claremont, which was actually down from the week before. It was 24% the week before, so it's starting to drop back down. We have had no hospitalizations with the primary diagnosis of COVID to date. We have reopened the drive-through testing facility out front. Folks can drive through and have their COVID test out front. We're still giving COVID vaccines in the vaccine room, along with we've started giving flu shots now. Those are available and we're giving those. We are still down to one operating room. Our building is rather old. It was built in the 70s, and there was issues with the flooring. They pulled the floor up, and the concrete underneath had just pretty much disintegrated. So they came up with their plan, and they're starting work today to redo the concrete underneath the flooring, and hopefully, I'm told that by the end of October, we should have both ORs up and running again by October, and we can be back to full speed. Any questions?
Questions for George? I see none, George. Thank you.
Thank you.
Okay, next up, Cherokee Nation Health Services, Dr. Steve Jones.
Good afternoon. You all have my report in your packet. A few things that I just want to mention that's coming up. I know we've had several requests for community meetings and having vaccine or flu vaccine at the community meetings. We're starting to get some of that in, but it's coming in a lot slower this year than it has in the past years. We will start vaccinating our health employees in 2 weeks, and then after that, we'll be ready to start the public vaccine efforts. So you'll see that coming out as we start to put that calendar together, and we'll work with you guys to make sure we hit the meetings that you need us to hit also. But anyway, that's enough of that. COVID vaccine, I know there's been some news articles out and stuff. That's not coming out till probably late October or sometime during October. The new vaccine that's going to cover the most latest variants, I guess. So, but we're not seeing that in-house yet. So, in case you're getting questions about that. I know we had scheduled the council orientation, and then budget hearings kind of ran into that same week, and it made things real difficult, so we backed out of that. We're looking to reschedule that the first or second week of October. You'll get some information. I think we'll get it to Gail, and then we'll start trying to work through that process also. So I know that that's a little difficult to make everybody's calendar work, but we're working on trying to accommodate that. Again, like I said, most of the things are in my report that are normally in there. One of the things that you guys had passed a resolution and asking us to look and work with Claremore Indian Hospital to come up with some ideas or some collaborative efforts to make things a little easier and to work through those processes. And you gave us a deadline of September to come back with a report, and we've had a work group working through that. So I have Mr. Hale with me today. He's the project manager. He's been leading that effort along the timeline, and so he's going to give you a little bit of an oversight of that. And there's a handout here with our report put together, some operational issues. So from that standpoint, if it's okay with you, Chair, I'm going to let Mr. Hale come up and talk about that. And I don't want to steal his thunder. He's been working very hard for the last 9
Dr.
months
Jones,
on
I might
this.
see if there's any questions anybody has for you. Any
Yeah,
questions?
I can
for
come
Doc?
back up too. I can come back up after he gives
Okay,
his,
we'll do that.
because there may be questions in that too that
Okay,
we need to
all right.
answer. Okay?
Mr. Hale.
Good afternoon. I think all of you have the white paper that we've developed. We have completed our evaluation of the current state of purchase and referred care at Claremore Indian Hospital, and part of this included a lot of information gathering, review of policies and procedures, meeting with the PRC staff there at Claremore, asking for their insight and their perspective, as well as meeting with patients that have had recent experience with the Claremore PRC. And I thought I'd give just a little bit of background. Purchased and referred care is a program for medical and or dental care that is provided outside of an Indian health service or a tribal health facility. And IHS has policies that specify who's eligible for that care. And while we typically use the older terminology of contract health services within Cherokee Nation, the newer nomenclature is purchased and referred care. And so just for clarity, I'm going to adopt the term purchased and referred care, or PRC, as I'm giving this update. And I thought it would also be kind of helpful to also talk about the differences between inpatient and outpatient care, because it's relevant when we talk about PRC. So think of inpatient care like checking into a hospital. So when someone needs medical attention that's for a serious condition, or if they need surgery that requires an overnight hospitalization, that's considered to be inpatient care. So that's more severe or complex in its nature. Inpatient care requires to stay in the hospital, involves 24/7, just around-the-clock care. Whereas when we talk about outpatient care, think about more like visiting one of our clinics. Outpatient care is typically for less severe issues, like getting a flu shot, having a checkup with your family doctor, or maybe even getting stitches for a minor cut. You go to the healthcare facility for your appointment, you get your treatment or your checkup, and then you leave. Whereas when we talk about inpatient care in a nutshell, that's for more serious health problems, where you need to stay in the hospital, where you have to stay overnight. And so a lot of that surgery now is being done on an outpatient basis just because of advances in surgical care. But for the most part, when we talk about inpatient, think of an overnight stay in a hospital, whereas an outpatient is going to be more of like a clinic setting in one of our outpatient health centers. Many years ago, Cherokee Nation compacted its portion of the PRC program at Claremore for outpatient care. And this assumption of portions of the PRC really created a division of responsibilities for purchased and referred care between Claremore Indian Hospital and Cherokee Nation. And because Cherokee Nation has compacted its shares of purchased and referred care on the outpatient side, we're responsible only for Cherokee Nation citizens residing within Rogers County and North Tulsa, with Admiral Boulevard being kind of that dividing line for that purchased and referred care delivery area. So Claremore Indian Hospital provides most of the inpatient PRC for patients north of Admiral Boulevard and all outpatient PRC in Tulsa County. Muskogee Nation, as you all know, compacted its outpatient shares And that only affects Muskogee citizens in Tulsa, Rogers, and Wagner counties. For inpatient services, Muskogee Nation is responsible for its tribal citizens in Mays, Craig, Delaware, Nowata, Rogers, and Tulsa counties as of October 1, 2021. So the only outpatient shares for Cherokee Nation that remain are for tribals, or for the non-indigenous, and we talked about that term when we previously reviewed this. Non-indigenous refers to American Indians or Alaska Natives other than Cherokees that reside within that reservation. So some of our findings that are in the white paper, I'll go over some of the highlights, is that limited funding is available for Claremore PRC, which that leads to deferred or denied care. Claremore's PRC budget is $6.1 million annually, and that's apportioned into $117,000 each week for PRC. That funding is based on the user population within the Claremore PRC delivery area. And because that demand for purchase and referred care is greater than what is supplied through funding, there has to be a priority system for Claremore to make decisions about who gets funded and who does not. The 2021 IHS user population report reflects 119,000 total users for Claremore Indian Hospital's PRC, with 63% of those folks being citizens of Cherokee Nation. In fiscal year 2022, Claremore PRC processed over 16,000 referrals and is projected to process over 18,000 in FY 2023. It appears the referrals have a 40 to 45% approval rating with a 55 to 60% denial or deferral rate. And so after a denial or a deferral, the patient can appeal that at 2 different levels. Some of the other significant findings we found were response time, adequacy of funding, accessibility and communication, as well as PRC staffing. And Claremore has recently added additional staff to their Claremore PRC staff. They've worked to improve issues, including communication with patients. They've adopted a new system so that patients are notified faster of their referral decision. And they've piloted a program using nurse case managers within that PRC system to serve as navigators. And that's garnered a lot of positive feedback from patients. And we believe a lot of this success is due to those nurse case managers being on site at Claremore. We did visit with some patients about their experience with Claremore PRC, and one of the biggest issues identified was a lack of communication. Other issues we identified were patients were sometimes required to serve as the courier between Claremore PRC and the vendor providing their care, referral statuses not being determined and communicated quickly, and reports of vendors not being paid timely, which results in patients receiving delinquency letters. And so while patients do receive the care that they've been referred for, there are some challenges in how to deal with that, and Claremore PRC acknowledges those. They've added staff and begun using that new system to notify patients, and I should notice that PRC is a complex environment. Cherokee Nation has to work diligently to improve its operations as well so that we become more patient-centric. Claremore PRC has increased communication between their staff and vendors to improve the patient's experience. As I said, piloting a program using nurse case managers to serve as a go-between for those folks. So going forward, we want to continue to work with Claremore PRC and the hospital's leadership to improve that experience for everybody. We'll also continue gathering information and engaging in performance improvement projects for both teams. Our immediate recommendations, many of which we've already begun, include a monthly meeting between Claremore PRC and Cherokee Nation's PRC staff. These meetings will include a focus on vendor education and management, as well as identifying points of contact so that we have folks that can serve as a navigator and and serve to kind of bridge the gap for folks that are caught in between the two systems. We also appreciate Claremore PRC staff having an increased on-site presence that improves availability to the patients, helping with accountability as well as communication. Some of the long-term recommendations would include that they need to modernize and standardize their software used for referral management and claims adjudication. Claremore is a federally operated facility that currently utilizes RPMS, and that system is over 50 years old. It is a goal of the Indian Health Service to migrate to a commercial off-the-shelf solution for their EHR, and that'll be a great step forward in improving the PRC operation and the experience of the patients that deal with it. I'm happy to try and answer any questions or clarify anything based on that white paper, whether that's today or if you have questions later you want to call me or email me about. We appreciate this resolution. We believe that it prompted this evaluation so that we can help improve the experience for all of our patients. I'm happy to try and entertain any questions.
Questions for Mr. Hale? Dora?
Could you back up for a second when you were talking about the 40% and the 60%? Clarify what, again, that was. 40% are approved?
They have a roughly 40 to 45% approval rating, 55 to 60% are either denied or deferred.
Thank you.
Any others? Danny?
Yeah, Mr. Hale, on page 7, you've got 4 where you're going to take the 5% of the monies from the gaming revenue. Does that mean we have an office over there now that people will know when they've been denied where they need to go from there or not?
We do have an office over in Claremore with Cherokee Nation PRC staff.
So so every Cherokee that's denied through Claremore, it goes directly to that office, and that office handles it where the patients don't have to anymore and don't get dropped in the cracks?
They should be able to use that office for appealing, yes.
But they still have to go to that office when they've been denied.
That's my understanding, yes, sir.
So we as counselors on that end of the reservation need to be pushing them into this office.
Correct.
Thank you.
Johnny?
Sir, thanks for coming in. Great report. Just to follow up what Danny was saying on page 7 on that number 4, where it says that Cherokee Nation PRC intends to review these referrals and potentially fund needed care through that 5% that's already legislatively mandated to come in from the gaming revenue. Is it your or this report's determination that there is money left in that 5% to be able to fund the entire delinquency or what they are not able to fund at Claremore right now?
I believe we typically have money left in that 5% fund, yes.
Yeah, keep in mind that's just for Cherokee citizens, of course. So yes, so far we have had plenty of money to pick up any of those referrals.
Thank you.
Councilor Callison had just previously asked you about the appeals office. Where is that located? Where exactly do we direct Cherokee citizens to go?
I don't know the exact address, but I can get it to you. It's right there in Claremore, but it's not close to the hospital.
Yeah, it's in a little strip mall area.
If you get that address, could you send that to tribal council, please, at your earliest convenience? Thank you.
Mike?
That percentage seems awfully low, the approval percentage. So why are most of those, or have you even looked at why they're denied? I mean, that's, because we're up a lot higher than that. We're in the upper 90s. And I know a lot of times whenever, we get their denials and they do their appeals and they go through their 2 times and they're done, they come to us and we pay for it. So, I mean, why are so many being denied on that side? Have you looked at the reasoning?
The main driver is a lack of funding.
So do they get the same funding as us?
No.
How much less?
I don't know the answer to that, because it's built on the geographical location of where that clinic serves. And so I can't tell you that. We don't have total access to their budget to look at that from that standpoint, so can't really tell you. We can probably find that answer out for you, but I don't know what that answer is. That's where that 5% money picks up that Councilor Kidwell was referring to and Councilor Callison. So that money that we have setting for Cherokee-only money, that's where we pick up that those appeals when they're denied there and they come through us.
I understand that. That's not my question. It's just, yeah, if you would, find out how much, I would like to know how much they have.
They have $6.1 million for their entire user population.
Okay, for the year,
Correct.
for contract health. Okay. And how much is that per month? Do they do it by months?
They apportion it to $117,000 per week.
Per week? Okay. Thank you, Chair.
Joe?
Just following up on Speaker Shamball's deal, 4 months ago, we talked about the money that we were doing a pass-through, and we were like 75 or 80% take care when Creek Nation and them had pulled their shares out. I mean, that was like 23 million, something like that. Is that close? But either way, the 75, 80% was pretty high. And then that's all coming past you through Cherokee Nation. So we're talking about the number being so low. And you would think that would be able to cover a lot of that, not have to come through Cherokee Nation on the contract health side. Is there some kind of reason why that money is not being used before it has to come to contract health through Cherokee Nation? Or is that used specifically for infrastructure and paying employees, or how are they appropriating all that, the funds that we pass through?
I'm not sure which funds you mean.
Well, we talked about this 3 or 4 months ago. I'm just going off the cuff because it's been a while. But we were doing like 80% of the money because everybody else had pulled out. So we had calculated how much Cherokee Nation was doing a pass-through to IHS. And that's covering 80%. That's a lot of money. So I'm just trying to figure out where the overlap is, why there's such a difference.
So are you referring to the shares?
Shares and the amount of money where we figured out that total. Yes.
Yeah, when Creek Nation pulled out, then our
Yeah.
share, obviously
It
our
went up.
percentage went up.
Yeah.
Yes. But we don't take money from our budget and put into their budget, if that's. if
There's
that's
no
what you're
pass-through.
calling it. There's not a pass-through.
Okay, so there's not a pass-through. Okay. All right, that's what I wanted to clarify, because the ratios didn't equal up, and that's probably why they didn't equal up. All right, thank you.
Danny?
Mr. Hale, you talked about that it was geared up to take care of North Tulsa from the boundaries, 21st Street, Rogers County. Now, my understanding is that everything on that outpatient deal from about halfway between Peggs and Locust Grove to the north and the west goes through Claremore. So you lost me there when you said it was only geared up to do Highway, 21st Street North and Rogers County, because all of Mays goes through there if they've got an outpatient deal. Is that not correct?
There's a geographic location around, that's called a CHISDA, and anything in that geographic location goes. I think what we were trying to, say in that paper is that's how far into Tulsa and Rogers County it
Oh,
goes.
okay. That doesn't give us like,
No, that's
because we've
just-
got Mays and Delaware and you know, Craig and Rogers and all those others up through there. So
Right.
that's what, that $6.1 million is there to
That
take
whole
care of
area.
all those people at that area.
Yes.
On a contrast, that's probably not a good question to ask, so I won't ask that one. There we go. Thank you.
Victoria?
Yes, thank you. Back on the off-site office, these people that are going to help with, or are helping with the issues of people that have received bills and they weren't paid and they're referred to collections, has that already taken, are they already working on those now?
Yes.
Okay. Can you give us names, later, names and phone numbers of those employees? Because I have an issue with just someone 2 weeks ago that was referred to collections. And I didn't know who to call, so I called Steve Carey's office and never heard back. He happened to be on vacation and I left a message, so I still don't know if it was resolved, and this person is under cancer treatment currently, so I need that as soon as
If you'll
possible.
send that to me, I'll follow up and make sure it was resolved. Steve's really good at getting those things resolved, so.
I know.
I'll just follow up, make sure it was done.
I will. Thank you so much.
Yeah.
Thank you, Chair.
Okay. Any other questions for Mr. Hale? Mike?
I will make this comment, since you brought his name up. Steve Carey does an outstanding job. He always is very receptive, and he really tries the best he can to get things resolved. So say nothing but great things about that man. He's very, very kind of a go-to guy, so it's a good man.
We agree with you. Yeah, absolutely agree.
Okay, were there any questions for Dr. Jones or Danny?
Dr. Jones, this is a positive thing, but I seen in your report where, your third-party revenue for the clinics is way up and for the hospital way up. Can you kind of give us what you guys think the reason is for that is? Because that's always a positive for us.
Yeah, a
That's
lot
a
of it
plus.
a lot of it has to do with Medicaid expansion. That's a lot of it. It also has to do with our department that looks at and meets with patients when they come in. They have no third-party resources, and we have some patient advocates that are aggressive, I guess, in trying to find something for everyone. Because not only does it help us, it helps them if they're not in range of our health system and they're out somewhere and something happens to them, it gives them those resources. So those two things together have attributed to a large majority of that. Yeah.
Well, thank you, because it's in the millions of dollars, and
It is.
we appreciate what you're doing to help us get better health care.
Yeah. I do want to mention one thing that, and just to give you some perspective in Mr. Hale's report, and when he said that Claremore is somewhere between 16 and 18,000 PRC contracts that they'll be looking at for this year, just to put that in perspective with Cherokee Nation, we are 11 to 14,000 a month. So just to give you an idea of the difference in the size of our contract health versus Claremore's contract health. So.
Any other questions for Dr. Jones? Sasha?
Thank you both for your report. I was just looking over some of the numbers that were reported for the month of July. Do you ever report some of the CMS indicators along with these reports?
So exactly which ones are you looking for?
Like your primary C-section rate, your exclusive breastfeeding rate, us being a baby-friendly facility, but also how close are we to reaching the new CMS standard for birthing friendly as opposed to being a baby-friendly facility?
If you would send me an email on what things you'd like to be reported on that nature, I'll be glad to put something together and send it out to you.
Okay, thank you.
Any other questions for Dr. Jones? Thank you, Dr. Jones.
All right. Thank
Appreciate
you,
it.
guys.
In the public health, it's Lisa Pivek or Dr. Gann. Looks like Dr. Gann is here today.
Good afternoon. Good to see all of you. Lisa's out today. She sends her regards. The big news since the last time we were here, we had our site visit from the Public Health Accreditation Board. It was a pretty big deal. And we got our preliminary report last week that we met all the standards and measures. There's always room for improvement. They gave us a handful of recommendations. The final accreditation won't come down till November, so we won't know 100% till then, but all reports are good. As you might know, Cherokee Nation was the first tribal public health department to become accredited in the United States, and hopefully we'll be the first one to become reaccredited. So hats off to all the whole team that went through all the work, and you can really see the effects of this whole process on our public health department. We're really doing some amazing things, as you can see in the report. Also noted in the report, Lisa's been appointed to several boards and executive boards at some national organizations regarding public health, specifically representing tribal public health across the nation. I think it's a testament to Cherokee Nation support that you all have given to our public health efforts. As I listen in the back about contract health and purchase and referred care, know that the investments that you're making in our communities is going to eventually decrease the need for contract health dollars. And it's hard to see right off the bat, but a new walking trail, I used the splash pad in Hulbert as an example of eventually that's going to improve the health of that community. When kids and their parents and grandparents have a safe place to play, doing something that's healthy, plus it brings the community together as well. So know that the Public Health Department's working on the prevention end with all of you, and the support we've received from the chief and the funding has really been significant, and we're working hard in all of our communities. I know COVID's back in the news, and that's what you usually hear me talk about. I think the number of cases is going up nationally and in the state. Those numbers aren't reported as far as the number of cases. We just don't get that. It seems the national trend from a public health perspective is keeping track of the hospitalizations. That's an indication on the impact that COVID is having on our healthcare resources. So the data that I can see, it's simply people who are in the hospital and people that have COVID. So there's not a good indicator people are getting that sick from COVID. Talking to our emergency medicine physicians, they're telling me that they are seeing a lot of COVID cases, but they're not nearly as sick as they used to be, right? So now keep in mind that if I break my leg and I go to the hospital and I have COVID, that still uses up a lot more resources than if I didn't have COVID. So it still has an impact. Plus the opportunity for someone with COVID to spread it to the staff and other patients is still there. So it is important that we track that. Deaths are a little bit more difficult to monitor because there's often a variable delay between when someone dies and the data shows up in our graphs. CDC has just about finalized the data from last year, from 2022, and, I still get the questions, when are we going to treat this like the flu? I can tell you in a bad flu year in the United States, 40,000 people die. In 2022, there are 244,000 people who died in the United States. So we're not even close, right? COVID is more contagious and more deadly and more severe than influenza. We're just kind of getting used to it a little bit. So we can't ignore that. And also, on a national level, American Indians and Alaskan Natives are disproportionately effective. The rate for the general population of deaths from COVID was 61 per 100,000, and for American Indians, Alaska Natives, it was 86. So it's higher. I can't speak to Cherokee Nation itself. There's a book that came out a couple of months ago. It's called The Contagion Next Time, and it's an epidemiologist who wrote the book from, I think, Boston College. And he discusses why in the United States we had such a hard time with COVID, because we started out as an unhealthy population that was assaulted by this highly contagious and deadly virus. So that's our public health perspective, right? The way for us to battle the next epidemic is to make our communities healthier before it comes. But there's a section of the book, a small section, where the author particularly picks out Cherokee Nation and what Cherokee Nation did when the pandemic hit as an example of what communities should do, and contrasted it directly with what the state of Oklahoma did in two different situations, right? But the work that Cherokee Nation did during the pandemic has been noted by the academics as the way to do it. So I thank all of you for your support with that as well. The latest data on the vaccine that I can find is that the way they're studying the COVID vaccine is they're giving it to people, then using their blood, and in the lab testing their antibodies that they've developed against the virus in the lab, and it's all good news. The two most concerning variants right now, the XBB 1.5, I have to write them down because they're changed so often, and the BA.2.86 is showing good activity. There's a big concern about the second one, the 2.86, because it had a lot more mutations on the part that attaches to lungs. But in the lab, at least, the antibodies that people are producing are very effective against that. So if you ask me today if I recommend that you get the vaccine, of course I do, right? Like I've always recommended. The more data is coming out on long COVID and the long-term impacts on formerly healthy people that get a mild case of COVID and have lingering effects across numerous body systems. And it's even worse for people, even high-risk people who have a mild case because they got vaccinated or didn't get vaccinated and did okay. Long-term effects are real, and the scientific community is studying those as best they can. So the main goal of the vaccine is to keep people out of the hospital, to keep our health services operating. They just don't have the time to study the vaccine to see how well it prevents someone from getting infected. So that's all the COVID for this month. Sorry. Yeah. Can I answer any questions?
Danny?
Yeah, Dr. Gant,
Sir.
there was some talk during the COVID epidemic, when it was high, that the virus is only going to mutate so many times. And now here we're coming back with all these different variations. Is it, and of course, understanding, is it just going to continue on? Is that what's going to happen, or?
Yeah, so from studying other viruses, right, there's hundreds and hundreds of variants of this virus. So some of them aren't very good at what a virus wants to do, so they don't take hold and infect a lot of people and they die out. So the idea is eventually the virus is going to mutate to a point where it's very contagious but doesn't make people very sick. And we don't know when that's going to happen. So in the meantime, we try to protect ourselves with the staying healthy part plus the non-pharmacologic methods. If you're sick, stay home. If you're sick, get tested. If you're not feeling well, wear a mask when you're around others, things like that. And then eventually we'll get around to the virus not killing 250,000 people a year in the United States. That's the hope, but there's no way for scientists to figure out a timeline about when they expect that to happen.
Thank you.
You're welcome.
Candace?
Well, thank you for joining us this afternoon.
Yes, ma'am.
Always a pleasure to hear from Public Health. I understand that, and I may have missed this may have already been stated, but the new iteration of the COVID vaccine, is that available now, or when do we expect that to be available?
So it's not available now. FDA meets today to consider approval, and CDC is planning on meeting tomorrow to do the other part of that approval and establish some guidelines. We don't expect to have any on hand until late October. And again, that's an estimate.
Okay, and so the vaccine recommendations, would you remind us of where those are currently?
Well, that's what CDC's
Oh,
part
okay.
of the job. Early indications are recommended to everyone. So
Okay.
remember before, we rolled out a small amount and started with healthcare workers and people at significant risk, immunocompromised over the age of 65, things like that. But I think they're going to roll out with enough for everyone.
So, and I'm already starting to see signs for, get your flu vaccine now. So, is it Cherokee Nation Health Systems, or is it Public Health that does like the flu clinics and the drive-through stuff, or?
That's health services. I'm
Okay.
sure we'll likely participate, public health will, out in the community.
Okay. And flu vaccines are definitely recommended.
Oh, yes. Yes, ma'am. And again, it's not only to protect yourself, but to protect those around you, just like with COVID.
Okay. So in terms of vaccine education programs, is that going to be Cherokee Nation Health Systems, or is that Public Health?
I think that's both, right? We just put out the news that the vaccine's available and it's safe and effective. I've heard some, even the Surgeon General from Florida has said some really difficult things that I don't agree with. Said this vaccine hasn't been shown safe, right? The one that's coming out. And it's using the same technology as the former vaccines, just like with influenza. We can't do the new influenza vaccine on 100,000 people every year to see if it's safe and effective. It's using the same technology, just a few different molecules of the RNA that are in there that are different. So based on what we've seen, I would be surprised if more than 20% of our population get the COVID vaccine, which is really sad to me as a healthcare provider, as a public health person, that a lot of people are going to get sick and likely some will die when there's a proven way to help prevent this. But, we're here to take care of people as best we can.
Right. Right. So I ask those questions mainly as a reminder to the individuals who may be watching today that vaccines are safe, effective, and accessible in our Cherokee Nation health systems.
Yeah. And if you have questions, talk to your physician, or pick up the phone and get in touch with me at Public Health, and we can discuss it. So I was just reading a book on the history of the polio vaccine, and I understand we have some historical trauma with that. And I think it was 1955. They had several companies making the polio vaccine, and one company, something got messed up in a ventilation fan, and 260 people got polio from the vaccine, and 11 of them died. So when we have that in our memory, saying, I don't trust anyone with a vaccine, from my perspective of the public health medical director and the physician, the vaccine is safe and effective, and the more people that get it, the better for the Cherokee people. So I compared a lot to driving a car. We all most likely drove here and none of us died. And I can tell you all about statistics about how dangerous driving is. And you're crazy if you drive. If you don't drive, you won't die in a car wreck. But we do. But there's things we can do. We can be sober. We can wear a seatbelt. We know our headlights work. If it's raining, we have windshield wipers. The government gives us permission to drive, right? We have a license to do that. So it's kind of with COVID, all these things are available to you to protect yourself and your community. Wearing masks, getting tested when you're sick, stay home when you're sick, and there's vaccines available too. And there's medication. If you get COVID, there's medication that will decrease the time that you're contagious.
Absolutely. Well, thank you for that, and thank you for the time, Chair.
Okay, Victoria?
Yes, thank you. Hi, Dr. Gann.
Good to see you.
I have a question regarding the community walking groups, and I was noticing in the book that my county, Craig County, has a walking program Mondays and Wednesdays, and there are only 3 participants, and then I see, well, it starts at 6 a.m., so I can see why only 3 people would want to get up that early. Who actually puts that on?
That's our public health educators, and let me get with them and see why it works out that way. It might be geared towards employees, you know, so they have time to walk and get cleaned up and get to work on time.
Yes, I was just interested to see if, A, there are other times available. So,
Sure.
you know, I don't know who even conducts that. I saw the address, and that happens to be the county buildings, and so it still doesn't tell me much about that walking program.
Yes,
So
ma'am.
I'm just interested for people that I know that could do that in Veneta.
Yes,
I don't
ma'am.
live in Veneta, or I would do that, but anyway, thank you.
You're welcome.
Mike?
Well, I think it's a great thing that, to be recognized for your efforts in dealing with COVID. And I think that's important, and it tells people, you know, that what you're doing, which they should see that anyway, is working. And it's looked upon as maybe the cutting edge or the way how it should be done. I think that's a big feather in your hat, and I know that's not why you do things, but at the same time, boy, it's good to have that affirmation that, you know, because there was so much talk, you know, that it was too strict and all these things, and, you know, you get calls and even the anti-vaccination stuff. But, you know, when you're little, and I remember, I don't know, you probably all remember this too, whatever that, they used to give him with those guns. You know, I remember those, be scared to death, those guns, but you had that one scar, that round scar.
It's a
and-
smallpox. I still have
Smallpox,
mine.
yeah, right here. I mean, most of us probably got it, but, you know, later in life, as you get older and those things happen, you don't have a clue what's going on when you're young, but, you know, taking care of your kids and maybe instilling those things in them is important too, because, you know, you've always trusted your parents and to do the right thing, and unfortunately, it doesn't always happen, but in that respect, you know, we trust you. I mean, because we
Thank
don't really know, we read, but you've done a good job in taking care of our nation, I guess, is the bottom line, and we're happy to support, you know, what you guys have done. You've done a good job.
Thank you. Cherokee Nation is all about community and working together, and the council and the chief and the whole executive branch. And we're a team, and it works.
Thank you, Chair. Junior?
For our elders remember last year we were saying COVID and flu shots, take them together. Would you recommend they go ahead and take their flu early?
You know, someone else asked me that today. When should I get the flu shot? And it's, I don't know. You know, we're not seeing much flu right now, so I don't know which way the curve is going and when it's going to peak. I recommend to my mother and my in-laws, they get the vaccine when it's available. 'Cause it doesn't matter if you get the flu in October or you get it in January, it's going to hurt you. And I know I'll have to look at the CDC guidelines again about boosters for elders or the higher dose vaccine for elders so it lasts longer. So I need to take a look at that. I get the flu shot when it becomes available, partly because as a healthcare worker, I'm exposed more often to people who are likely to have the flu in the hospital. So, but yeah, I don't have a firm recommendation on when you should get the flu shot as an elder.
Okay, thank you, Dr. Gann.
Thank you.
Thank you. I see no old business pending. Under new business, looking at resolution number 1.
Chair?
Yes.
Excuse me. I need to make a motion to remove this from the agenda.
Okay.
It's been
Second.
pulled.
Okay. All those approve, say aye.
Aye.
Any opposed? Okay, so this is being removed from the agenda. Thank you, Councilor Vasquez. Number 2 is a report from OSU College of Medicine at Cherokee Nation by Dr. Natasha Bray. We look forward to this. Dr. Bray, welcome. Thank you for your patience. I made particularly new counselors, it's quite an asset for us to have a medical school, Cherokee Nation. We have over 200 doctors now in training at the campus, so we look forward to this report. Go ahead, Dr. Ray.
Can you guys hear me okay? All right. So I put some slides up, and I wanted to share some information with you where we are. I think probably the first thing just for everybody to realize is we're in our 4th year, which means we'll actually graduate our first class on May 16th, 2024. So we're really excited about that. Next slide. You can actually go forward too. Go one more for me. There you go. Just a little bit of history about Oklahoma State University and the College of Osteopathic Medicine. We were created by legislature act by the state of Oklahoma in 1972. We became part of the OSU system in it's up there, sorry, in 1988. Fast forward to 1997, we became a Center for Health Science, and what that means is we went from having one degree program, the Doctor of Osteopathic Medicine, to adding other degree programs. So today, we have a physician assistant program on the Tulsa campus. We have master and PhD programs in forensic science, healthcare administration, biomedical science and fields. So there's a lot of degree programs. There's an athletic training program that got added over time. In 2006, so going back almost, we're getting close to 20 years now, the Cherokee Nation started hosting medical students for 3rd and 4th year rotations at WW Hastings. And that's really kind of an important thing because that set in motion where we are today. So as you took our students on clinical rotations, they had the opportunity to learn and study and have experiences in family medicine, surgery, peds, internal medicine, OBGYN. 2 years later, the family medicine, or 3 years later, the family medicine residency program started. And if you look back on the history of that, that was really a partnership between OSU, Northeastern Health System, and the Cherokee Nation to open that program. The family medicine program today is fully operated by the Cherokee Nation within your health systems. And we opened the campus in 2020. Those of you who are around and paying attention then, there was a lot of things that happened during that time. We were in the middle of COVID. So to open a medical school campus with a new facility during COVID really presented a lot of unique challenges. On behalf of OSU, I can't say thank you enough because Cherokee Nation was an outstanding partner in that experience. And Cherokee Nation Health made sure that we were actually able to open the campus even though our facility wasn't done. So they allowed us to use some of that community educational space that's within the outpatient healthcare center. Next slide for me. The mission of OSU is really about primary care physicians and getting those primary care physicians to rural and underserved communities. So when we started the partnership, it was really important that it aligned with OSU's mission, but it also aligned with the mission of Cherokee Nation and your investment that you've chosen to make in the healthcare and in the future health of your citizens. Next slide for me. So at the ribbon cutting for the new facility, Chief Hoskin really made a wonderful quote. And as we mark the official opening of the first tribally affiliated medical school in the United States, we know that one day we're going to look back and what will matter most that our efforts have changed the lives for better. He said, I believe in this partnership will advance quality health care for all by allowing us to teach a new generation of medical professionals to serve our communities. And that's really where our focus is. Next slide. So I'm going to give you a little bit of an overview of where we are. We really talk about our medical school really being founded on a learning environment that's based on this concept of belonging. We want all of our students who come into the environment, all of our faculty and staff that are in that environment, to feel like they're part of the community. So we have lots of programs that look at high school and even younger students, exposing them to opportunities within healthcare, talking to them about what we're doing, talking to them about the possibility that they can become a physician, they can go back and serve their communities. The big circle is wraparound, so we have lots of services that wrap around our students. Whether we're talking about recruitment experiences, community experiences, learning environment, mentorship, what our faculty are doing in the curriculum itself, it's all designed to circle the student and support them in having their educational goals and needs being met. And then we want to follow them as they go out into practice and make sure that we create opportunities for them to have residency training and that we support them when they're out in practice practice. So we have things like Project Echo that expand learning opportunities while they're out in the community, because it's really scary sometimes going to a community as a new graduate and a new physician and not having someone you can call back and ask questions and feel supported in caring for your patients. Next slide. So some of our pathway programs that we have, and there's a whole bunch that are on here, and we're happy to talk about these extensively. But what I would emphasize here is we want to reach students in lots of different ways at lots of different times as they're developing in their educational trajectory. We have programs that are targeted to all students across Oklahoma, and then we have some specific programs that are run through our American Indians in Medicine and Science or our Native American Primary Care Center of Excellence that specifically target Native students. So we want to create opportunities. So some of the big things, Operation Orange is a one-day immersion experience. What is it like to be in medical school? We do a lot of really fun things that's targeted to 8th through 12th graders. This year on our campus here in Tahlequah, that'll happen on Saturday, March 2nd. And we would love to see all the kids from your communities as part of that. We bring them in, we talk about what does it mean to go to medical school. We teach them to intubate and do chest compressions. They get to see what a heart and lung looks like that are healthy and one that maybe has had a little bit of disease struggles so that they're not as healthy of organs. And we talk to them about process. How do you go from junior high or high school into college? What are the steps you have to take then to get to medical school? Things that are geared more towards college-age students, if you know any college students who are interested in the process of applying to medical school, we have a Native American pre-admission workshop that's happening on October 28th on our campus, and really that can be anyone very early in their freshman year of college. What order of classes do they need to take? Or someone who's at the point of applying and they're working on their personal statement. They want to ask, what needs to be in my personal statement, what's not appropriate to be there. We'll walk them through that process of what it looks like to apply to medical school. And we even do mock interviews with them, and we do those in two ways, in person, so sitting across the table and having a mock medical school interview, but we also do those via Zoom. We at OSU do all of our interviews at this point. We're back in person, but there's a lot of medical schools that are still doing interviews through Zoom, and that's a different skill set. So we want to make sure that the students, whether they come to us or they choose to go to medical school somewhere else, that we're supporting them in developing the skills to be successful. Next slide. Overview of demographics. This is one of the things that Dr. Dobbins wanted me to give you an idea. So the Tulsa campus is there for each projected graduating year, and then the Cherokee Nation campus has the black line around it. So just starting with the class that just started in August. So they'll graduate in 2027. 18 of our 52 students are Native American students. Of those, 9 are Cherokee, if you want to know that percentage. But on the Tulsa campus, and I think this is really important, we have 17 students in that class of 114 who are also Native American. So if you're Native American, you don't have to come to our campus here in Tahlequah. We make sure that we support the students that are in Tulsa as well, and making sure that they have opportunities. Students have different learning needs. They may have a partner who needs to work in Tulsa, and so it may make more sense for them to be in that community rather than this community, and we want them to be successful. But we have those demographics going across. The fourth year class, the class that's getting ready to graduate, 12 of the 54 students in that class are Native American. So if you crunch all those numbers together for our 208 students that are on the Cherokee Nation campus between the 4 years, we have 50 students who are Native American. Comparing that to national, where about 0.2% of matriculating students are Native American, we're much closer to about 25% of our students. So it's something that we're really very, very excited about. The URM stands for underrepresented in medicine, so that includes our Native American students as well as Black students and Hispanic students, students of Hispanic heritage. So you could have those numbers up there as well. If you look at Oklahoma residents, about 80 plus to 85% of our students are from the state of Oklahoma. And if you look at rural, and that's based on the HRSA definition, so based on how they define rurality. We average around 60%. If you look across, we tend to have a little bit higher percentage of students from rural backgrounds than they do on the Tulsa campus. And we would expect that. Students who are going to want to come to Tahlequah are looking for something in a rural community, and they have a dedication to that. And our male to female, you see the numbers bounce all over the place. We stay pretty close to 50-50 when you average it out across the years. Next slide. Another question that I get asked a lot are what tribes are represented. So this gives you an overview of the tribes that are represented on the campus. Next slide. And I get asked about hometowns. So rather than putting every hometown for all of our students there, I gave you the fourth year class that's getting ready to graduate in 2024, as well as the class of 2027. So it gives you kind of an overview of where the students are coming from that are on our campus. I'll let you look at that for just a minute. All right, next slide. One of the things that's really unique to OSU, when you look at medical school curriculums, a lot of times students go to medical school and then they do their clinical rotations, those third and fourth year, in large academic health care centers or big hospitals. For OSU and Tulsa, that would be OSU Medical Center. For OU, that's University Hospital in the VA in downtown Oklahoma City. We allow our students the opportunity to, we describe it as a distributive training model. We want our students in those third and fourth year rotations to go out in the communities and learn and develop their skills in communities that they want to serve. And we think that that's really important. So we supplement that education to make sure that they have outcomes, that they learn everything that they need to learn to care for patients, and they're highly trained. But you learn a lot of things being in small towns. If you come to Muldrow, where I live, you're going to figure out that your closest 24-hour pharmacy is Tulsa or Russellville, Arkansas. And you can't learn and understand what that means for patients unless you're actually part of that community. So when we want them to develop the skills to serve those communities, they need to know what the barriers and the challenges are within those communities so that we can begin to support them in understanding how do you overcome those and how do you take care of people so that we are really doing an excellent job providing care. So we have both a rural medical track and a tribal medical track. And what those mean is they spend their third year core rotations, their required rotations, internal medicine, general surgery, pediatric psychiatry, family medicine, general surgery, OB, peds if I didn't say it, emergency medicine out in either for rural critical access hospitals across the state of Oklahoma. For our tribal track, they're going to be within tribal health care centers or Indian Health Service facilities. So we really want them out in those communities learning and growing, hopefully developing a passion for being part of those communities as they continue within their education and their careers. Next slide. So this gives you an idea of where we send them. So we really want our students to train where they want to practice. So the black dots are the tribal sites. The orange triangles are rural, and you'll see half orange and half black. That's because they can count for both, and a lot of those communities have more than one clinic that are in there. So this is an area that we continue to grow. It's really interesting when I looked up here because we also have rotation. Well, Lawton's on there. Okay, I was going to say we have Lawton also. So we continue to add these rotation sites and expand them out. To put a student in a rural community, we have to have a board-certified physician who's actually there 5 days a week, and that's one of the challenges with some of our rural sites is that we may have a provider that's there 2 or 3 days, and they're supplemented by a nurse practitioner or a PA, and just from an educational outcome standpoint, we need to make sure that they have somebody that's supervising them at all times that's board certified. Next slide. So in addition to that, we want to create a learning environment, as I said, where students feel like they belong. So we have a lot of cultural elements within the school, and I'm really excited whenever you all have the opportunity to come and see the school. It is a beautiful facility. I would argue pretty passionately that it is probably the best equipped and best medical school in the country, and there's a lot of reasons for that. But part of that is some of the elements that are within the building. We are very grateful for the art that's from Cherokee artists that's throughout the building. It gives us an opportunity to really talk about the intersection between culture and health and how we come together to heal and grow. The Talking Leaves collection is a library collection. It's up to about 320 books. We reached out, and we continue to do so, to the culture and language departments of the different tribes across Oklahoma and asked them to make recommendations to us for what books go into this collection. We have grant money that we use to pay for it, so we're not asking them to give us the books, but we want books that the tribes feel represent them, rather than us just dropping in books that might happen to be about historic events for Native Americans. The Heart Kits are heritage enrichment art kits. They're basically do-it-yourself kits. They're 30 to 60-minute small art projects. If you click on the QR code, it takes you to a video from Cherokee Nation Cultural Department, Arts and Culture, and tells you how to do the project. So we've done corn husk dolls, we've done corn bead necklace, pinch pots. I'm running out of what some of the other ones. They're really designed, though, to be about 30 to 60 minutes where if the students or staff are feeling stressed and they're overwhelmed and they need a study break and need to use a different side of their brain, they can go to the library, pick one of these up, and do something that allows them the opportunity to have learn a little bit about Cherokee culture and the role of art within that culture, but also to decompress a little bit from the stress of going to medical school. Next slide. I think it just has some, we do things like Rock Your Mocks Day. The students are really excited this year in October. One of the Cherokee Nation National Treasures is going to come over and actually help them make pucker toe moccasins. So they're going to do that in October, so that in November they'll be able to wear their own moccasins that they've made. All of our cultural events and art events that we do are for Native students and non-Native students. We want everybody in the community to feel welcome there. It's an opportunity, again, to just share and learn about the patients that we intend to serve. Next slide. It's just a pretty picture so you can see them doing different art. Next slide. As I said, we aren't finished with our students when they graduate. They have to do residency programs. So OSU continues to grow and develop residency programs across the state in our rural communities. These programs, we have 10 rural residency programs. 4 of those are tribal affiliated programs at this point in time. This excludes our programs that are in Tulsa and Oklahoma City. So we have about 160 residency positions. Here in Tahlequah, we have the family medicine program that's at the Cherokee Nation, the internal medicine program that's at Northeastern Health Systems, and then we have a rural track at the pediatric program that's at Cherokee Nation. What a rural track means for residency is the program is accredited through Tulsa, but the students spend about 27 of their 36 months of their residency training here in Tahlequah. One of the challenges with pediatrics is there's some requirements that we can't meet here. They have to do a certain number of pediatric ICU months at a level 1 and a level 2 pediatric ICU, and same thing with NICU. So we need to have them have that subspecialty training. So they go to Tulsa for that. The rest of the time, they're actually here within our communities. We also have family medicine programs with the Chickasaw Nation and with the Choctaw Nation. Next slide. So I always like to give you outcomes, because I told you that we've had a family medicine program here in Tahlequah for going on with graduates for approximately 10 years now. So the question should always be, okay, what does that mean, and is that a good investment? So this is combined data. So you can see the family medicine programs. This starts with the graduates from the Cherokee Nation program in 2012 and goes through 2023. So there have been 74. Well, let's look just at the Cherokee Nation numbers. There's been 40 graduates from that program, from that family medicine program. 14 of them are working in a tribal healthcare system or within Indian Health Services. So it's about 35% of the graduates from your program. If we look at those that are in practice in Oklahoma, 63% of them are in practice in Oklahoma. That's 25 of your graduates. If we look at who's in rural communities, 65% of them are in rural communities. If we look at rural or partially rural, so that's that kind of not a suburban community, but counties are defined for this on partially rural. So that means they have pretty rural parts, and then they may have a little bit that abuts into a suburban area. 80% of the graduates are in those communities. If we look at those that are in HPSA scores less than 20, so really underserved communities, you have 80% of your graduates in those communities. So to me, this speaks volumes about the importance of the work that we're doing, because we know one of the biggest challenges in the physician pathway in workforce distribution is getting physicians to the communities that actually need them. So your program is training physicians, you're training them well, and they're actually serving the communities that need physicians. Next slide. So just to give you, I'm going to focus on Dr. Beck, and those of you who may know Dr. Beck, because he's really a story of success. He came from Wagner, Oklahoma, went to Northeastern State University, went to med school at OSU. He was an IHS scholar. He did his residency here with the Cherokee Nation Family Medicine Program and graduated in 2014. He's been with Cherokee Nation Health Services since that time, and he's your program director for your Cherokee Nation Family Medicine Residency Program. So if you think about, I talked about that we're really focused on how do we start with those high school students, those junior high students, inspire them to go into medicine, train them in an environment where they feel supported and can be successful, support them into their residency, and then support them into practice. He's a wonderful example. Ashton Claiborne is the other one who is up there. She is from Porum, Oklahoma, the big city of 607 people. She also went to Northeastern State and went to OSU. She did a rural track, so she was one of the first cohorts that was in that rural training track. She did her residency with the Choctaw Nation, and she's the program director at the Choctaw Nation now. So it really talks about that continuity and building a workforce to really serve our communities. Next slide. I think that's it. I'm happy to answer any questions you have, and I want to say sincere thank you for allowing us to be your partner and continue to do this work.
Hey, so when will we find out when the application process for, is it Operation Orange, that day?
Yeah, so you can go on OSU's website, and I can actually, I'll send the link to Dr. Dobbins where it has all of our outreach pages. I don't think the registration for that is up yet, but it will be soon, and I'll make sure that you all get that specifically. Okay, I'll wait till it's up. It's okay. And it's always on all of our social media things, both the schools and mine personally. If anybody follows me, I tend to post things everywhere because we want to get that out. And, you know, it's funny because we posted to what was Twitter, now X, and Facebook, and all the kids are not on any of that. We probably need to be on TikTok, but I don't know how to use that. I'm not that with it, I guess.
Any other questions for Dr. Bray? Junior?
Being so close to Northwest Arkansas and all those hospitals over there, do y'all track how many go over there?
Yeah, I can tell you actually where all of our grads from OSU go. We actually have a interactive just graphic thing where you can actually go by year and look to where the graduates go. I don't know where our students are going to go yet. So we have to wait. Match day for this class will be, I think it's March 15th of 2024, so we'll know where our class is going for their residency training at that point. Until then, I don't have data on where we are here and what that success looks like.
But none of them do any residency over in Northwest right now?
Oh, they can. So residency application process, what happens is the students, they don't do third and fourth year rotations. Once they get in their fourth year, all of our fourth year students right now are going through the application process. They're going and doing audition rotations, which is basically a month-long job interview. Please take me into your program. I can tell you, looking at how they're doing those rotations and how they're scheduled, probably of the, we had 2 students who are going to graduate next year because of all the things that happened in education that had them drop back. But so we've got 52 that are looking to graduate. Probably about 30 of them are looking at family medicine. And then we have a spattering of other opportunities. A lot of them want to go into OBGYN. I've got a class that it feels like every single one of them wants to go into OBGYN. That's not quite true. It's probably about 10, but it feels like a lot. So they will go through and they'll apply, and then once they've done their auditions, they've interviewed at programs, they go into what's called the match. So they put in their list of programs that they want to go to, and they rank them 1 through however many they rank. Programs do the same thing, and then it's essentially a lottery where the student's preference, if a student ranks me number 1 and I rank them number 1, it's easy. They match, they come to us for residency. So there's an unknown element here. until we get the results of what that process is. I do know that I have 2 students who are interested in internal medicine who are doing rotations in Fayetteville at one of their internal medicine programs, but that's as close as I can get as guessing right now.
Okay. Any other questions for Dr. Bray? Really appreciate your presentation, Dr. Bray.
Thank you so
Very
much.
extensive. Thank you very much. Appears to be our last new business item. Announcements. The next meeting is tentatively scheduled for Monday, October 16th at 2 p.m. Any other announcements? Need one more motion. Is there a second? All those in favor? Okay, we are adjourned.